to just explain our product, that is Rotem, that is rotational fungal liquid. So today I discuss just a technical overview, and I know you already have a class at around 11:30, so I'll just finish it out as soon as possible. So I'll just share a bit of technical overview of the machine, how we can use that, and what are the activators and what are the reagents we are using just to cope up with the bleeding, and how the thermogram should be read and how the interpretations should be there. So I'll just brief you with some of the slides. So these are the basic parts you already know. Everybody you have already known about this. So I'll just refresh it by having the look on that. So we all know hemostasis and coagulation. We have is just to maintain a balance, that is a coagulation and fibrinolysis. And so these are the systems that are involved in hemostasis, that are vascular system. We already know where platelet plug is formed, and then is the coagulation system where all the factors of intrinsic and extrinsic pathways will be there to produce a fibrin plug. So we have these three systems to initiate the coagulation. So this, I guess, you already know. So what are the things we already have in the blood system? Plasma, red blood cells, platelet, and obviously the fibrogen, which is basically synthesized by the liver. So these are the main important part of hemostasis, that is primary, secondary, and tertiary. So primary is always the platelet plug formation. So right now we are covering the secondary and tertiary hemostasis because our product basically works on the second and third part. So second is activation of clotting cascade. Yes, we do have a complete scenario for activating the clotting cascade, and deposition of stabilization of fibrins, how the strength of the clot basically. So how good is the strength of the clot. And third is tertiary hemostasis, where the hyperfibrinolysis will be there. The clot is stable, but it also get dissolution. The lysis of the clot will be there. So this is our product. Basically, these are the advanced product we have. This is Rotem Sigma on the right side, and on the left side we have that Rotem Delta, which your esteemed hospital already have. So this is just an overview. I just show you why I'm showing this slide, because our reagents work on these three parts. So we have intrinsic pathway, we have extrinsic pathway, and we have a common pathway where fibrogen converts it to fibrin. So we have different activators for intrinsic pathway, where we can initiate factor that involves intrinsic pathway, and we have a tissue factor. We are using it in our reagents to activate the extrinsic pathway, and yes, we have the complete scenario for fibrogen to fibrin conversion. So where we can check the strength of the clot, whether the clot is getting lysed or not. So this is just an overview which are the coagulation disorder that can affect on which part of the pathways. So if we talk about hemophilia A, B or C, they have a low or absent level of factor 8, and hemophilia B either or low or absent level of factor 9, C with factor 11, and yes, the von Willebrand disease, that is a protein that is required for platelet clumping and stabilization of factor 8. So obviously the vitamin K deficiency, that is factor 10972. So this is basically a continuation of this slide where we can affect the pathways. So these are some drugs that basically acts on extrinsic, and heparin acts on intrinsic pathway. So we have a test that is known as heparinase also. We do have Rotem test to neutralize the heparin, and so now we comes to our product, that is Rotem Delta and Sigma. So Sigma is the upper version of Delta, but we have Delta over here that is also utmost in. So there is a PBM approach. So PBM is basically patient blood management. So how we can manage the bleeding part. So we have three pillars. The first is to optimize red cell mass. Obviously we are treating first the red cell mass, that is anemic patient. So first we have to neutralize with the anemic patient, then we comes to how we can minimize the blood loss or bleeding, how we can stop the bleeding, and which are the therapies we have to give to minimize the blood loss. And third is the harness and optimize physiological reserve of anemia, whether that has been recovered or not. So our Rotem basically works on minimizing the blood loss and bleeding. So how we can minimize the blood loss? We can, I'm sharing this slide. So whenever we have an acute bleeding situation, whenever our patient is bleeding, so what is the right therapy? So always we are thinking what should we have to give to the patient to stop that bleeding. So whether the hemostasis disorder, is there a coagulation cascade problem, or is a surgical bleeding, or which drug patient is using, what blood products we have to give the component therapy so that the bleeding should be stopped by avoiding unnecessary blood transfusion. How much dosage is required and at what sequence we have to give to the patient to stop the bleeding. So these are some therapeutical options which can cause the bleeding, that is DDBAB, that is I think oral part. Any antifibrinolytic enzymes we are using to stop the bleeding or that causes the bleeding. Protamine, obviously we are using in the cardiac cases, and any local or surgical procedure that is causing the bleeding, and any blood products which is required to stop the bleeding. So as a rule, only appropriate therapy will stop the bleeding. So whatever the patient is required, we are just transfusing the only that part. So whatever the blood required to stop the bleeding, our Rotem product basically gives you a component therapy to pinpoint the deficiency why patient is bleeding. So obviously we are transfusing blood, but there are also on the other side we have that different adverse effect of transfusing. So that can be related to TACO, that is transfusion associated circulatory overload, transfusion related lung injury, TRIM, and any anaphylaxis or any allergic reaction should be there. And this also relates to negative effect on basically morbidity and mortality, more length of stay to the hospital, and that can be complications will be there, and of course the hospital cost is on high priority. So this is basically a traditional approach that is going on in an acute situation. Either we are clinically experienced, we are using our experience part to that approach, or we are using a standard laboratory test which take around 30 to 35 minutes or maximum 40 minutes to reach that level to stop the bleeding, or we can think of that what product we have to give to the patient. So again the same slide, whether it's a altered hemostasis or surgical problem, which blood product is required, which drug basically causing the bleeding, and dosage and sequence. So this is basically a W Health Organization report, and there is a statement by on PBM, that is a concept was highlighted in 2010 by the World Health Assembly as an important concept to improve patient safety, and all WHO members were requested to implement this concept in a timely manner. So this is basically a WHO statement. They are taking care of their main priority is to patient care, and of course to the hospital products they are using to transfuse on the patient. So yes, it's a multidisciplinary approach. We can use it as a multidisciplinary part. We have n number of medical articles and publications to prove that thing, and we can also optimize the patient own blood volume. Yes, we can minimize the blood loss, and yes, we can avoid unnecessary or inappropriate blood transfusion. How we can do that? We'll just start with this. So this is basically a Rotem product which we are discussing. So this is a Rotem thromboelastometry, and it has 4 channels. We can use it for a multiple patient, for example. And I just speak about the Rotem delta only. So what differential analysis Rotem delta will guide us? So basically, number 1 is coagulation factors of intrinsic and extrinsic pathway, because we have that activators which directly act on intrinsic and extrinsic pathway, and yes, with the common pathway also. So contribution to the platelet to the clot formation, basically we check the stabilization of the clot, the strength, and yes, the fibrogen level and its ability to polymerize, that is we can also check for hyperfibrinolysis. And heparin effect, if the patient is on heparin, we can also check the effect whether the reversal has been done or not. And yes, the clot stability and hyperfibrinolysis. So all these results are available within 5 to 10 minutes. So we have evidence-based amplitude at 5 minutes publications where we can pinpoint the efficiency while running the test within 5 to 10 minutes. So we have different algorithms for cardiac trauma and liver, PPH, postpartum hemorrhage also. So again, this is the same slide. So this is basically a which principle we are using it. So it was developed by Professor Hartwig in 1948. You might have heard about the tag machine. So the principle is same, but the complete obligations and complete thing is different from the tag machine. But in tag machine, what happens is the pin is on basically a pendulum wire. Pin is on wire and the cup is rotating, which makes it very less stable. Even if you push the machine, the graph will be impacted. Here, what we have done is the pin is basically on a ball bearing that give you a strength to the pin, and the cup is fixed so that the blood will not be splattered and it will not impact the graph. So this is how a tamogram looks like. It will give you graph like this. So we have multiple color coded thing for the parameters also. You can easily pinpoint which parameter is in normal range and which is above range. So this is basically what we are doing in our machine. So this upper part is in between the machine and this is the lower part which we are using it on the outer part. So we have a cup and we have to fix the pin to this ball bearing part, and the cup will be stable as we have already discussed, and the pin will be rotating at 4.7 degrees. The moment it it pinpoint the light source to the detector, it will give us the tamogram. I just show you a small video of that. It's not working over there. I'll just show you after. So basically, this is how tamogram.
How long is the video?
Ma'am, it's video is around 1 to 1 minute only.
Just a minute after
Yeah,
we
yeah,
can watch that. Just curious. Not working?
Ma'am, its voice is not working, but this is how the light source come to the detector, and detector will read this graph, just like this. So you will get the multiple color coded graphs. So we should know that which parameter is in the normal range or which parameter is the abnormal range. So we have different parameters. I'll just discuss about the parameters. So if you can see, this is our parameters range. So this is CT, basically a clotting time, and this magenta part is CFT, that is clot formation time. So clotting time, clot formation time, this is basically amplitude. Amplitude after 5 minutes, 10 minutes, 15 minutes, 20 minutes, and 30 minutes. And this is basically a maximum clot firmness, the strength of the clot, whether the strength of the clot is good or not. So now, afterward, when the maximum clot firmness is reached, we comes to the lysis part. So whether the clot will be lysing or not. So we can check at lysis index 30 minutes, 45 minutes, and 60 minutes. So these are the parameters which basically these are the main parameters which are on the main focus when we are interpretation. So CT is basically the time from beginning of the test until an amplitude of 2 mm is reached. So here you can see that this is basically time, 10 minutes, 20 minutes, 30 minutes, and this is our amplitude, 20, 40, 60. The moment it reaches to amplitude of only 2 mm, This is
in
what.
mm, your amplitude.
Yes, ma'am. Amplitude is in mm millimeter. The moment 2 mm is achieved, that is our CT time, basically clotting time. So now this magenta part is basically a clot formation time. The moment from 2 mm to 20 mm is reached. So this will be our clot formation time. It also there are some main influencing factor. For example, our CT is prolonged or our CT is not in range. So the main influencing factor will be either it's a platelet, fibrogen or factor 8. So we can conclude that if our CT is not good, so we can think of that what factors they are contributing. So this is sorry. So this is clot formation time which we are talking about. If there is a problem with the clot formation time or magenta part, so that means our main influencing factors are platelet or fibrogen. So next is parameter amplitude. Amplitude means amplitude after 5 minutes, 10 minutes, 20 minutes from the CT. The moment we start CT, then only we can calculate the amplitude. So the amplitude after a certain limit after CT. So the main influencing factors are platelet, fibrogen and factor 13. So if there is any problem with the strength of the clot, we can conclude that there might be a bleeding either with a deficiency of platelet or with a deficiency of fibrogen. How we can interpret that? I'll show you the later slide. So the next is maximum clot firmness. It's a maximum amplitude reached to check the strength of the clot. So the main influencing factors are platelet, fibrogen, factor 13 or the status of fibrinolysis, whether the fibrinolysis is there or not. Then is lysis index, the relation to the amplitude to the maximum clot firmness. So any fibrinolytic enzymes are there or any inhibitors we are using or factor 13. This will be the responsible factors when there will be a lysis index. Then it's a maximum lysis, that is because this graph will automatically run by default for 90 minutes. So you can check it. So this is the same slide, clotting time, CT, clot formation time, amplitude, maximum clot firmness, lysis index, maximum lysis and lysis onset time. So ma'am, for the research purposes only, we have around 40-45 parameters. You can research on that, but the basic main parameters for interpretations are these only. So ma'am, these are the tests we have and these are the activators we are using. That's why our machine turnaround time is very less. So we have XTEM test. The tissue factor we are using is the activator we are using is a tissue factor, because tissue factor directly initiates the factor 7 and it comes to the common pathway. So the analyses are the clot formation, fibrin polymerization, fibrinolysis via exchanging activation. Then is INTEM. INTEM basically we can say that we have two pathways, intrinsic pathway and extrinsic pathway. So XTEM is for extrinsic pathway and INTEM is for intrinsic pathway. So the activator we are using is ellagic acid. So again the analysis could be done that the clot formation, either fibrin polymerization, fibrinolysis via intrinsic activation or influence of heparin. So we can give the component therapy so that we can give a patient a direct transfusion. Next is FIBTEM. FIBTEM, APTEM and HAPTEM. These are basically a confirmatory test. So the FIBTEM basically we have a tissue factor plus cytochalasin D. So tissue factor means we are adding XTEM with the FIBTEM to check whether the fibrogen, the patient is having a healthy fibrogen or not. So this basically works on elimination method. So we have a cytochalasin D as an activator. This cytochalasin D activator is a very good platelet inhibitor. What he can do is, he will inhibit the platelet part and it will always give you only the fibrogen value. So we can conclude that if my fibrogen is healthy, that my patient might be bleeding due to platelet deficiency or vice versa. Next is APTEM basically is a tranexamic acid we are using to check the hyperfibrinolysis. So we can avoid unnecessary tranexamic acid when we are giving the baseline to the patient at the time of surgery. HAPTEM we are including it with INTEM because we are checking the heparin level, whether the reversal of heparin has been done or not. So we have a calculator also in a machine so that we can check whether the protamine dose. We can also check for the protamine dosage and if heparin reversal has been done or not. This is how it works, ma'am. So these are the tests which we are discussing. So XTEM is basically activation of clot formation by tissue factor. Assessment of the factors are factors 7, 10 and 5, 2 and 1 and fibrin, platelet and fibrinolysis. So ma'am, this is basically a normal thermograph. If you can see, these are the green dotted lines. So these are the normal values. So if this green part is my normal, so see this is the CT and this magenta part is clot formation time and this amplitude, basically the blue part, is basically a mixture of platelet and fibrogen. So where we have amplitude after 5 minutes, 10 minutes and so on, and this is a maximum clot firmness which we already discussed. But when the clot is at the maximum firmness, we can check the strength of the clot, and this is the lysis, whatever lysis we have, whether the clot is lysing or not. So if you can check in INTEM, our CT is slightly prolonged. It's not prolonged, but it's a normal value. So we have a range of around 38 to 79 seconds in XTEM and 100 to 240 seconds in INTEM, because intrinsic pathway is a little longer because we have multiple factors over there. But in XTEM we have only one factor, that is factor 7, we are initiating. Here we can, so this is basically a FIPTEM test. So the activation same as XTEM, and we are adding cytochalasin D as an activator, which basically a platelet blocking substance. So the fibrogen level and fibrin polymerization can be assessed in a functional way. So this is basically my XTEM test, which we have already discussed. This green part CT, this magenta part is clot formation time, and this basically a blue part is a mixture of platelet and fibrogen. The moment I add the cytochalasin D into it, the moment we run the FIPTEM test, it only gives us the this magenta part, because the platelets are inhibiting in this. So we only get the fibrogen level. So if my fibrogen is healthy, so we have a reference range for that. If my fibrogen is healthy, that concluded that the patient might be bleeding with the platelet deficiency. Or my fibrogen is very low, we can conclude that there might be, we have to give to the fibrogen first and then treat the patient. So ma'am, we can see that there is a low amplitude as compared to the normal one. So this is a normal one, and this is the amplitude is very less. So we check the FIPTEM test, amplitude is normal, there might be a platelet deficiency, and if our amplitude is very less, that means there might be a fibrogen deficiency or any polymerization defect, either we are using any antifibrillary defect. So here, this way we can interpret whether what patient basically requires to stop the bleeding. So this is ma'am ACTEM. We are using tranexamic acid as an activator to check whether the patient, whether the hyperfibrinolysis is there or not. So we are always run this ACTEM with the XTEM. So here you can see it's a fish-like graph. So this is basically a lysis part. The moment we add tranexamic acid to the blood, so the correction has been done. So this is how we can treat the patient hyperfibrinolysis with hyperfibrinolysis by giving a tranexamic acid. So this is ma'am HEPTEM test. HEPTEM is to check the heparinase level, whether the reversal has been done or not. So if you can see in this graph, significantly shortened CT. This CT is prolonged in normal test. So when we done the HEPTEM test, INTEM test, the CT is prolonged. The moment we check with the HEPTEM, the moment we add heparinase to the blood, so we'll just get the correction. The CT has been corrected from 1500 seconds to 138 seconds. My normal value is 100 to 240 seconds. So we can check that the patient is still having a heparinase effect. And these are the some delta reference ranges to check whether our patient is our gratemogram is normal or abnormal. The moment we get the abnormal graph, it always gives you a red mark that this parameter is in abnormal range. So here ma'am, this is basically a complete scenario. So whether if we are on a heparin influence, our extem CT is normal, but intem CT is prolonged. The moment we check with heptem, the CT is corrected. You can come to the platelet efficiency, or amplitude is very less. The moment we check with the fiftem, we added cytogenesis and D as an activator, we get the correction, and that means the platelet efficiency is there. If we go for the fibrinogen deficiency, we can have that low amplitude in both extem and intem. The moment we run the fiftem test, so the fiftem value is very less. So that means my patient might be bleeding due to fibrinogen deficiency or this. So this is a hyperfibrinolysis we can check to run by the aptem test, which is basically tranexamic acid as an activator. So the moment we run the aptem test, the correction has been done, and we can check for the hyperfibrinolysis as well. These are the main basic scenarios we basically to check the interpretation. So these are the again same slide we are using. We can check for the coagulation factors of both pathways. We can check the contribution of platelets to the clot formation. Yes, the fibrinogen level can be polymerized, and ability to check the polymerization of the fibrinogen. Heparin effect, we can also check that, and the clot stability. Ma'am, this is the basically limitations of yes, the machine do have the limitations. So first of all, the platelet inhibitors, if the patient is on aspirin or clopidogrel, so that cannot be gives you an idea about why patient is bleeding. And yes, the poor sensitivity to reoccur detection requires Rotem platelet. So we come up with another module, that is Rotem platelet. That is now basically a verify now to check the aspirin and clopidogrel effect. And yes, it will not give you the exactly von Willebrand syndrome. We can always run with the pathways only. Not a single deficiency will be treated by the Rotem. So anticoagulants, if patient is on anticoagulant and low molecular weight heparin will not be, it's very poor sensitivity to low molecular weight heparin, and yes, to the direct anticoagulant the patient is using. So in that case, Rotem will not give you a guided therapy. So ma'am, this is how it basically works. It gives you a result in 5 to 10 minutes. You can pinpoint the deficiency and to stop the bleeding, and we can also avoid the transfusion wherever they are inappropriate. So this is how we can take care of the patient and how the PBM is approaching.
Your machine is functional, no?
Yes ma'am, functional.
I think for the
Yesterday only.
case today itself we can test it out.
So we have the reagents now.
Yeah,
If any
so
patient is bleeding, or even if you want to check, we can run it.
When you are using putamine, you just inform Dr. Rajni to send a blood sample, we can check.
So ma'am, we have algorithm as well. I just shared you the complete algorithm for cardiac, liver, trauma, PPH. So each and every algorithm is stated by if our value is this and how we can proceed that. If our value is less than this and more than that, what product should we focus on that? So FFP is our machine. FFP is at very bottom of that. So we are very less using FFP. We are always focused on first we check the hyperfibrinolysis, then we go for the platelet or fibrinogen deficiency. Even if the patient is bleeding, so we go for the PCC, and then only at the last we are using the FFP, because we know even we transfuse one pack of FFP also, it will leads to this transfusion risk. So that's why the FFP rates gone down very far. So this is how basically a beauty of this machine. Sorry?
The algorithms, where will you share?
Algorithm, ma'am, I'll share. I have the algorithm. Yes, this is cardiac. Yes. So ma'am, this is a cardiac algorithm. So it's a A5 means the moment we reach the amplitude at 5 minutes, so we can get how we can pinpoint things. Sorry. So the moment our extem, which we have already discussed, amplitude after 5 minutes of XTEM is less than 35 mm and CT of victim is more than 600 seconds, that means we have to give a tranexamic acid. The patient might be bleeding or they will be. Even if this is not the scenario, and we can run the ACT after protamine or ACT baseline. If the CT of intem and heptem ratio is more than 1.25, that means we have to transfuse with the protamine. The moment you start using it, the moment you can get
We
through
have to
it.
run simultaneously.
Yeah. Because if we know a patient is on heparin, to check the reversal of heparin, we have to do the intem and heptem test. And if we are checking for the hyperphenolysis, it's extem and heptem. And because main tests are extem and intem because we are checking for both the pathways. And
We can run 2 or 4 tests simultaneously.
yes, we can run 4 tests simultaneously. It's depending upon the patient condition. So we have 4 channels. Either you can use it for a single patient or you can use it for a multiple patient. Generally, in cardiac, extem, intem, fiftem, heptem, they are required because heptem to check the heparinase level and fiftem basically to check the clot
Or
strength.
we have to run in single sample.
Yeah, you can run on a same scale.
How much blood is required?
Ma'am, on a citrated oil 2.7 ml for complete testing.
For all 4 tests.
All 4 tests. Even if we are using for just 2, you can have the half vial also. But the problem is they are always a 3.2 that sodium citrate, na? So at least we need that 2.7 ml.
2.7 ml in EDTA vial.
No, just citrated vial, the blue cap vial. Whole blood can be used, yes, whole blood only. And if our amplitude of extem is less than 30 mm and fiftem, that we have spoke about the fiftem is more than 9 mm. So that means my fiftem fibrogen is healthy. The patient might be bleeding due to platelet deficiency. We have to give the platelet concentrate. So we can pinpoint the deficiency why our patient is bleeding. The moment you start using it, you can get your experience as well. Even if these things can be changed according to your experiences, but you can follow for some time. Then only you can recognize that yes, this machine is helpful and guiding therapy.
Which is the other algorithm,
Ma'am, we have a lever algorithm as well.
We will. Show us trauma, we get more of trauma also.
Yes, ma'am. We have. This is for trauma. So, ma'am. So, ma'am, this is the trauma. So, you know, in trauma there was a lot of bleeding will be there. So, the moment we get an extem of A5 and CT of 50 more than 600 second, again the tranexamic acid. First we are checking for the hyperphenolysis and then we go for the fibrogen concentrate or platelet, whatever the scenario is. And last, if everything is normal, only our CT is prolonged, the clot initiation is prolonged, then we can go for the PCC or FFP if there are. And at last, this is basically for CT of intent, intrinsic pathway. If more than 240 seconds, we can consider the protamine. So this is how we can go through towards the transfusion.
For PPH, you follow.
Sorry?
For postpartum
Yeah.
hemorrhage, will you have separate for that also?
This is PPH.
PPH, trauma, cardiac.
I think we need to share this with all of us.
Yes, ma'am.
How
I'll
do
just
you-
email you each and every algorithm,
Yeah.
and we can also paste it towards the machine also. So even if we are getting the results and we have to interpret, at least even a technician can interpret कि this is the scenario, and we can also paste it at the SOP how to run a test and what interpretation should be there.
Send it to my email and we'll make sure you get a printout.
Ma'am, today I will share the SOP as well as these complete algorithms. And there was a complete algorithm for protamine dosage as well. So these are basically just the first page of the algorithm. The rest of the page so how to calculate. Even though there is a calculation, ma'am, how even if we have to increase our figure into 2 mm, 8 mm, so how much concentrate we have to give or how much FFT or how much other cryo has been